Welcome to Public Health Ideas. My name is Sandro Galea. I serve as Dean of the School of Public Health at Washington University in St. Louis. These are conversations we're having to highlight work that advances public health science. Today, I have the privilege of speaking with Professor Ross Hammond. Professor Hammond is the Betty Bofinger Brown Distinguished Professor of Public Health at the Washington University Brown School of Social Work. We are here to discuss his paper in PNAS, Making Evidence Go Further, Advancing Synergy Between Agent-Based Modeling and Randomized Clinical Control Trials. Thank you, Ross, for joining.
Happy to be here.
Tell us a little bit about this paper. This is an unusual paper, Ross, to feature because it's more of a conceptual piece, but tell us where this paper came from.
Sure. This came really out of almost a decade of my participation in work trying to piece together evidence, a huge body of evidence on what drives the childhood obesity epidemic and what solutions will work. And time and again, we discovered that important gaps in that evidence base were holding back progress and sometimes very puzzling patterns in that evidence base. And I came to feel that system science approaches, a whole new set of tools that have come into population health relatively recently, might hold the key to unlocking those gaps and making more progress more rapidly. And along the way, I met my wonderful co-author on this paper, Dr. Sherry Barkin, who is the chief physician at Children's Hospital in Atlanta, who really has deep experience in the randomized control trial side. And she has also felt very strongly that system science and randomized control trials in particular might really work well together. And we're currently actually leading an NIH-funded project that's doing exactly that, partnering the system science technique of agent-based modeling with the empirical technique of randomized controlled trials. And we're studying what were previously really big puzzles in the patterns of physical activity in children. And we're making a lot of headway, and we became very excited not only about what we're learning in this particular study, but in the potential that this partnership of methods has to make the evidence we do have in today's complex world go a lot further and be much more impactful.
Yeah, I thought the synthesis in the paper was really interesting. Yeah. Let's talk about randomized controlled trials.
Sure.
So here's a quote from the paper. Randomized controlled trials are widely used in health sciences to establish causal relationships between interventions and outcomes. However, RCTs have limitations that constrain the impact of the evidence they generate. Let's talk a little bit about the limitations first.
Sure. Yeah, so I think there are three that I would like to highlight. The first is that almost every randomized controlled trial necessarily has a limited diversity in its sample, a limited time horizon in which can be studied, a limited amount of different contexts that can be studied, and there are just practical reasons for that. There are ethical reasons, there's cost reasons. And what that means is that we are then faced with the challenge of extrapolating. So we can, how can we make sense out of something which worked in suburban Boston that we want to apply in urban St. Louis? Will it translate? What would have to change to make it translate effectively? That's a question that RCTs sometimes struggle to help us answer. The second challenge is that RCTs are great at telling us what matters and what causal relationships there are, but they don't really tell us why those causal relationships exist. And that's not only a challenge for translating to a new novel context, but it's also a challenge for thinking about why an intervention works for some people but not for others. Randomized controlled trials don't necessarily tell us that. And also thinking about alternative formulations. If I can't exactly copy an intervention that was done elsewhere, and I'm going to do it slightly differently, how can I know what to expect? Because the randomized controlled trial only studied the things that were done in that particular trial. And then the third is a lot of randomized controlled trial inferences require assumptions, two of which I want to highlight, one of which is that you receiving the intervention or not has no impact on me receiving the intervention or not, which means there can be no social influence between us. And that's not true for lots of population health topics and behaviors that we care about where we know social influence is important. And relatedly, we tend to focus in randomized controlled trials on the average effect of a treatment. And that leaves out questions about groups for whom it does not work as well versus others.
So I suspect most people who are actually watching this video know about RCTs, or at least have a sense of them. Mm-hmm. But let's talk a little bit about agent-based models, which is much newer. Can you describe a little bit agent-based models and also strengths and limitations?
Sure, yes. So an agent-based model is a computational technique, a simulation technique for representing dynamic pathways that connect exposures on one hand, like for example, the retail environment around us and our individual characteristics, to outcomes on the other, for example, tobacco purchase patterns. And you can represent the pathways that connect those in what we think of as an artificial society. So we create an artificial society on the computer. And we use this first to learn more about the real world, about real societies, by inferring what the mechanisms, what the pathways that matter the most are and how they work. And then we use this artificial world to do experiments that we can't do or haven't done yet in the real world, in which we systematically intervene in the virtual world, in silico, if you like, in ways that we would hope to do in the real world in vivo later. And we learn things by doing that. So the advantages this gives us is a lot of insight into mechanisms, a lot of ability to handle differences between people and contexts, a lot of ability to look at many different formulations of interventions and their interaction effects. But along the way, we have to be sure that we build as much confidence in our models as possible, that we believe what's coming out of them. And to do that requires the right kind of data. And so one of the limitations has been being able to access the right kind of data to build and test these models. And that's where the circle comes back around, and randomized controlled trials enter as a benefit to agent-based modeling, just as agent-based modeling is a benefit to randomized controlled trials. And we can talk more about that.
So your paper, you talk about ABMs, agent-based models, as a potential intervention counterfactual, something you've written quite a bit about, I've written a little bit about, and you use the example of COVID. Guide us through how ABMs were useful during the pandemic.
Sure. So agent-based models allowed us to build very highly detailed representations of real places, of physical spaces, of social spaces, of demographic characteristics of populations, and then to simulate a huge array of potential interventions, different combinations of policy actions like mask mandates or distribution of vaccines or antivirals or home test kits, and all kinds of different combinations, many more than you could study in the real world, even if you were given a large budget and lots of time, and we didn't have the time during the pandemic. And so these models were used to understand what the potential implications of policy choices would be in this virtual world. And indeed, they were not only able to do that during the height of the pandemic, but they were able to go back afterward and figure out what we could have done differently and how that might have, for example, improved equity in the distribution of outcomes.
So now let's get to really the heart of what your commentary is about. Tell us a little bit about synergy between agent-based models and randomized controlled trials, and what are the benefits that emerge from these synergies?
Sure. So the synergies come about because agent-based modeling offers a great way to bridge that generalizability gap, to take something which was tried in one place, studied in one place, and understand what it means for a new context, a new setting, a new population. It offers the ability to take the empirical evidence we have and make it go further to new settings, but also to learn more from it than the randomized controlled trial alone can tell us by uncovering what these mechanisms might be, which in turn tells us why it worked for some people and not for others, or why it worked in the short run but not the long run. And those are very powerful added value to what the RCT alone gives us. And in the reverse sense, what you need to build and test an agent-based model is lots of repeated observations at the individual level across many different time points and contexts with strong sense of the causal relationships and the outcomes. And that's exactly what a randomized controlled trial is. So randomized controlled trials that exist allow us to build good agent-based models, to explain them and draw new insights from them. But then agent-based models allow us to make predictions, which we could then test with new randomized controlled trials. And that iteration, both Sherry and I see, is extremely powerful.
So where's this headed? You mentioned you have a grant that you're exploring.
Yes.
So what's next in this work, and where's it going to lead us?
Sure. So the work we're doing now is about childhood physical activity, and it uses an existing randomized control trial to build an agent-based model, which then has policy implications. Where we'd like to take this now is first to go well beyond obesity or physical activity. We think this actually has very broad implications for how we can make more progress more rapidly in a resource-scarce world in population health and in medicine. And secondly, we think that doing that is going to mean a more conscious embracing of this partnership, where you not only take a randomized control trial that happens to exist and use it to build an agent-based model, or use a model that happens to exist and use it to design a trial, but you actually design a cycle in which we have ever better models that help us design ever better trials, and that we're very focused in that iteration between the two. And that's indeed how a lot of science progress is made in other fields of science, in the basic sciences in particular, the physical sciences. There's this combination of predictive models and experiments to test them and improve them, and that goes on all the time. And we'd like to see more of that come to population health. And we think that agent-based modeling and randomized control trials are the right vehicles to help make that happen.
Well, as you know, I've long thought that population health benefits from this work. So thank you for doing this work.
Thanks.
Thank you for talking to us.
Thank you.